Good afternoon. My name is Tiffany Lopes, and I'm the Director of Communications here at the UCLA Center for Health Policy Research. As a land-grant institution, we would first like to acknowledge the Gabrielino Tongva peoples as the traditional land caretakers of Tovangar, that is, the Los Angeles Basin and South Channel Islands. Thank you for joining us for our UCLA Center for Health Policy Research seminar series and today's webinar, Demand for Aging and Disability Services Increasing in California. Can we meet the needs? Today, we will hear from Kathryn, a senior research scientist and director of the Center's Health Equity Program, and Nadereh, director of the Health Economics and Evaluation Research Program and associate center director, who will share findings from their new policy brief, which assesses the use of two important Medi-Cal programs that provide home and community-based services to older adults and adults with disabilities. While information about the number of people served by these programs is available, little is known about the characteristics of those who currently use these programs, and even less is known about the needs of those who may be eligible but are not currently enrolled. Doctors Kietzman and Pourat will discuss the critical need to improve access to these long-term services and supports that could keep hundreds of thousands of Californians in their homes and out of skilled nursing facilities. Next slide, please. Today's webinar is being recorded and will be posted to our YouTube channel in the coming weeks. As always, the recording and today's slides can be requested from our communications department by emailing healthpolicy@ucla.edu. Next slide, please. Again, thank you for joining us today. Now let's begin today's discussion with Dr. Kathryn Kietzman.
Thanks, Tiffany. Good afternoon, everyone. Thanks for joining to all in the virtual audience. Thanks for joining us today to talk about aging and disability services, the need for these services in California. Our study today that we're presenting was released as a policy brief a couple of weeks ago, and we'll be sending information, I believe, in the chat and towards the end of the presentation about where you can access the policy brief and the infographics. Before we get started, I definitely would like to especially acknowledge and thank Mimbera Haile and Xiao Chen for their essential contributions to this project. Both are senior statisticians with the Health Economics and Evaluation Research Program here at the Center for Health Policy Research. We couldn't have done this project without their statistical expertise and dedication. I also want to acknowledge and thank the California Department of Aging for bringing forward the idea to conduct this needs assessment and then supporting us to make this work possible. So to set the context for our presentation today, it's important to first consider the significant increases in population growth by age that are anticipated in the coming years in California, particularly among the older adult age groups. As this graph shows, an estimated 150% increase is expected among those 75 to 84 years of age in California by 2040. And a nearly 250% increase is expected in the 85 plus population by 2050. It's also important to note that the fastest growth of the aging population will be seen among older adults of color. Between 2012 and 2030, the proportion of Black or African-American older adults is expected to increase from 5.2 to 5.4% of the population. Asian and Pacific Islander older adults from 14.1 to 16.4%, and Latinx older adults from 18.3 to 26.3%. The growing diversity of our aging population needs to be front and center in all of our policies and related planning and program development efforts. As the population ages, many older adults and adults with disabilities need long-term services and supports, or LTSS, as I'll refer to them through this presentation. These services are designed to address a broad range of chronic care needs and are provided in a variety of locations, both in the community, for example, in people's homes, in independent living centers or senior centers, and also in institutional settings such as skilled nursing or assisted living facilities. Estimates indicate that about 14 million adults in the US need LTSS, while in California, the number has been estimated at close to 1.2 million. Unmet needs for long-term services and supports have been associated with poor health and social outcomes, as well as with other adverse consequences. And access to supportive services at home and the community is essential to maintaining physical and mental health and independence, as well as to preventing or delaying unnecessary or premature institutionalization. In California, two important Medi-Cal funded programs that provide LTSS services to older adults and adults with disabilities at home or in the local community are the Multi-Purpose Senior Services Program, or MSSP, and the Community-Based Adult Services, also referred to as CBAS. These two programs are the focus of the needs assessment we are presenting today. CBAS is a community-based day health program. It provides professional services at licensed adult day health centers to adults who are 18 years of age or older and who are at risk of needing institutional care. The individual must also meet specified medical criteria of any one or more of the 5 categories: being at risk for nursing facility placement, having organic, acquired, or traumatic brain injury and/or chronic mental illness, having Alzheimer's disease or other dementia, having mild cognitive impairment, or having developmental disabilities. The CBAS centers provide professional nursing services, physical, occupational, and speech therapies, mental health services, social services, personal care, hot meals, and transportation to and from the participants' residence. Because CBAS centers are located in the community, many are tailored to be responsive to specific ethnic populations and are staffed by people who are from the community. They're often well positioned to provide services in the participants' language, serve familiar and preferred foods, and offer social activities that are reflective of the local community and its cultural norms. In 2020, CBAS centers in California served approximately 38,000 individuals with LTSS, long-term services and supports needs. MSSP, or Multi-Purpose Senior Services Program, provides health and social care management to frail elderly persons 65 years of age and older who would otherwise require institutional care. The specific eligibility criteria includes being certifiable for placement in a nursing facility, being age 65 or older, receiving Medi-Cal under an appropriate aid code, able to be served within the cost limitations of MSSP, being appropriate for care management services, and not enrolled in another duplicative care management services program. Care management services provided by MSSP include conducting client assessments, developing care plans, and then importantly, following up to ensure that services are appropriate and well coordinated across different health and social care delivery systems. In 2020, MSSP served about 10,000 older adults in California. While information about the numbers of people served by these two LTSS programs is available, little is known about the characteristics of those currently using MSSP and CBAS. Further, no one has assessed the unmet need for these California programs. That is, the individuals who are likely to qualify and could benefit from these programs, but who are not currently enrolled. So recognizing the need for data to guide their program planning and decision-making, the California Department of Aging contracted with our team here at the UCLA Center for Health Policy Research to conduct a needs assessment of the MSSP and CBAS programs. In addition to identifying the numbers of individuals who would likely qualify but are not currently enrolled, California Department of Aging also wanted an idea of how much the demand for these programs is likely to grow in the future. So our research team collaborated with the program team at CDA, California Department of Aging, to develop and implement a plan using available and relevant data to generate these estimates. And now I'm pleased to turn the virtual podium over to Dr. Nadereh Pourat, who will explain more about our approach to this assessment and then walk us through the findings. Nadereh.
Hey, good afternoon, and thank you for joining us this afternoon. So I'll cover some of the details of our analysis, and I do invite you to have a look at the policy brief and other materials that are available on the website for further detail, and we're happy to answer some of the questions that you might have. The data sources that we used for the analysis included what you see here. We did look at available programmatic data from CBAS and MSSP programs, but most of the analysis that were conducted were using information on the individuals that actually are receiving these services as we could find them in the existing administrative data, which is Medi-Cal enrollment and claims. We then used available information from the California Health Interview Survey, which is a comprehensive source of information on all California residents. Is the best available data source to include, that includes data on characteristics of the population so that we could actually estimate who might be eligible for the program, for these two programs. And we also use the projections from the California Department of Finance on the size of the population in the future. And I'll go through these in a little bit more detail, and you can see, hopefully understand what else we did and how we did it. Next slide, please. So the first thing that we did was to estimate or at least identify the size of the users of these two programs and also define their characteristics. So the administrative data from the California Department of Aging, what is being reported to them, could give us an identification of the size, but the definitive data comes from Medi-Cal. This is California Department of Healthcare Services, where any services that are provided are billed to Medi-Cal. Therefore, it includes or demonstrates exactly how many individuals receive these services. The advantage of this data source is that it has a lot of the important data on the demographics of the individuals, such as age, race, ethnicity, language, preferred language for communication, gender, and also the location of these residents so that we could identify the California regions in which they may be residing. We did not, sorry, stay on the previous one. We did not actually directly gather the data from Department of Healthcare Services, but we worked with them collaboratively, and they analyzed the data and provided us with the size of the population and the demographics that you see here. Next slide, please. The second important task that we had in front of us was who is eligible for these services. Now, as Kathryn described, the characteristics that lead to eligibility include a number of clinical assessment information as well as specific diagnoses. Now, because we are using California Health Interview Survey and not actual records, health records for these individuals, which we did not have access to. So we'll have to make it clear that we are trying to use the best data available that could give us a reasonable and reliable estimate, but we were not able to actually look at exactly what conditions individuals have. So the first step that we did is try to identify individuals from the California Health Interview Survey that are likely to be eligible or could be eligible based on programmatic information and some information on their own characteristics. So programmatic information includes age. CBAS, as you heard already, is available to individuals 18 years of age and older. We know that the program is available to Medi-Cal beneficiaries. And it also is restricted to individuals at 138% of the federal poverty level, which is the majority of the Medi-Cal beneficiaries anyway. Then what we did is we also looked at questions that in the CHIS survey that indicated whether the individual had any issues with cognitive function, did they have any limitations for dressing or bathing, and if they had difficulties running errands. And for the CBAS program, we further examined two age categories, those 50 and older and those 18 to 49. And that's because the prevalence of conditions are different. And so we wanted to add a little bit more accuracy in how we identify who's likely to be eligible. For the MSSP program, that program is available to individuals 65 years of age and older, have to be Medi-Cal beneficiary, but the cutoff for poverty is a little bit different. It's under 100% of federal poverty level. But we also, again, utilize the information on cognitive function, dressing and bathing abilities, and difficulties running errands. So once we identified these individuals, clearly that not everyone in there is likely to be eligible. We then developed a model, and it's a random forest model. Anybody who's interested in technical issues, we're happy to talk to you either offline or maybe some simpler questions can be answered here. But we try to use a model that helps us do the best job of identifying who is likely to be eligible out of that pool of eligible populations that we developed. So, for example, that was about over 300,000 individuals that were in the pool for CBAS, and for the MSSP, that pool was smaller, somewhere around 200,000 individuals. So then when we did the random forest prediction model, we used all of the information that we had in CHIS to help us identify who's likely to be eligible for these services, a more refined estimate. We can think of it in that way. And in that case, we used all the demographics that were available in the survey. We used health status indicators, which include some chronic conditions. And then we also looked at the utilization of services that we knew about in the survey, including, outpatient visits to providers and emergency department visits, etc. Once we identified the likely eligibles, then we made sure that the population was reflective or resembled the estimates of the true size of the population by the geographic area, because we weren't only doing an assessment of who's eligible, but we also wanted to identify the California regions, and occasionally we might have been able to do this at a smaller geographic unit. You can imagine that those are important pieces of information for planning of how to address the needs of this population. Next slide, please. So our third activity, once we had identified who is currently eligible, and by current, we were using the latest years of data, which was 2019 and 2020. So that's what we mean by current. Then our next task was to project forward to the future to see how the size of this population is likely to increase. And to do that, we used the California Department of Finance projections for these age groups and the populations of interest as target. So we knew what is the total population size. And then we used again models to predict the size of the eligible population in those 3 time frames that we showed you earlier. So we did that, we repeated the analysis first for the state overall, and then we also did it again for the 7 California regions. And we also used the same approach that we did before by ranking the models so that our estimates are reflective of the geographic distribution. Next slide, please. So we're going to walk through some of our findings. So the very first task that we had was, what is the size of this population? And at a very high level preview, we did in fact identify a population that is likely to be eligible, that is about 6 times higher for the CBAS program. And for the MSSP program, we did find a population that's about 10 times greater, I should say. So just to put those numbers in perspective, in the next slide, we can see the difference in the size of these populations. So we have about 38,373 individuals that were users of the CBAS program in 2020, 2019, and our estimated eligible population is about 243,400, which is about 6 times greater. Similarly, for the MSSP, there are about 10,324 users currently, and we projected the estimate for the current eligible population is over 100,000 individuals. So that's about a 10-fold larger estimated size. So then our second task was, of course, to look at the characteristics of the population that are likely to be eligible. And we did find that there were differences between the users and the population that's likely to be eligible. For example, when we looked at age, the number of people that were 18 to 34 that were eligible for CBAS that were users was much smaller than what was estimated as eligible. And when it came to 65 to 74 years for the MSSP program, we found also a differential there. The same thing for race ethnicity. We did find that the number of individuals that are Black or African American that are currently using the CBAS services is indeed smaller than the size of the population that is likely to be eligible. And we also find for MSSP fewer Asian individuals that are receiving compared to the likely eligible. So why don't we put those in perspective? In the next slide, you can see these differentials indeed in both numbers and percentages. So here for the CBAS program, the pie chart that is on the top left-hand corner shows you the age distribution of the population. And you can see that the majority are those 65 and older. But when you look at the eligible population, there are a lot of folks that are younger, but and likely to be eligible, but are not currently users. So similarly, when you look at the CBAS population racial ethnic breakdown, you can see that you do have about, let's say, 37% that are reporting as Asian and about 36% that are reporting as white. But the number of users that are reporting as Black or African American individuals is only about 3%. And when you look at who's likely to be eligible, that number is much greater at about 14%. And there similarly for the blue, which reflects individuals that are of other race ethnicities, is actually the size is greater. Just a note here, the reason we're not recording all the different racial ethnic groups is just because sample sizes were not large enough for us to be able to report them. So they are all included in that last category of 2 or more. We obviously would like to provide as much information as possible, but the consideration of reliability is also very important. So that's why you're not seeing those numbers. So moving on to the MSSP program, you can also see some differentials. The age distribution, the differences are, it's the 75 to 84 population that in fact are the greatest, not the greatest, sorry, the second greatest users, but when you look at the eligible population, in fact, it's the 65 to 74 that are likely to be eligible, but are not using MSSP services. And when you look at race ethnicity, you'll see that there are a much larger population, about 37% that are white that are users, but in terms of when you look at the eligible, the population that is potentially underutilizing is the Asian population. So that portion of the pie is a lot greater. So, I mean, there are obviously limitations in our analysis. What we don't have access to, for example, is of the people that are likely eligible but are not using, what might be some of those reasons? Is it because they have support, other forms of support, or is it because, you know, is it cultural or language difficulties that are keeping them from using services, or are there supply constraints? There may be a multitude of issues that are responsible for these discrepancies. Moving on to the next slide. So our next, so here we are also showing the distributions of the populations, both for CBAS eligible population and the MSSP eligible population in the California regions that we were able to estimate. For example, you can see in the northern and Sierra counties, dominated by a lot of rural areas, you have a very large likely eligible population, 65% for the MSSP, and for some other areas, for example, in the Los Angeles area, the likely populations about for CBAS is actually quite large. It's about 38%. And we just wanted to, if you go to the next slide, just to give you an idea of the service providers. These two maps come directly from the California Department of Aging. They have these very useful maps that show you where the providers are and the areas that actually are actively served. And you can see, for example, for CBAS, there are the number of providers in the Los Angeles, Southern California area is quite a lot, but obviously there's some of the rural counties in the state that do not have providers. And for CBAS providers, I won't make a statement about their service areas, but you can imagine that, you have to be relatively close to be within driving distance to be able to use those services. So it sort of gives you an idea of that supply. And then on the MSSP, you can see that there are providers sort of, there's of course a little bit more in the Southern California area, but they're also distributed in other parts of the state. And for example, if you look at Shasta, you'll see that there is a service provider there that is serving Shasta County and 4 other counties in the surrounding area. So those are relatively significant distances that are served by a provider. So just to put it in perspective, and let's move on to the next slide. So then the other activity that we had was projecting growth in both of these types of services over time. You can see that we expect that, it stands to reason that the size of the eligible population is going to grow, as you saw earlier, because the population is aging and frailty is associated with aging and need is associated with aging. So we projected about an 8% increase for CBAS and about 18% increase for MSSP. And if you go to the next slide, you get a better idea of the projected size for each one of the populations. For example, in 2020, we had estimated 243 likely eligible population, and by 2050, that number is going to be 261, more than 261,000. And for the MSSP population, which are the yellow bars, you can see an increase from over 106,000 to over 125,000. Move on to the next slide, please. Okay, so at this point, I'm going to hand it back to Dr. Kietzman, who's going to walk us through the discussion of the findings and the implications. Thank you.
Thank you, Nadereh, Dr. Pourat. Appreciate you walking us through all of that. So I think the results of our needs assessment suggest that there are sizable gaps in access and uptake of the CBAS and MSSP programs in California that need to be addressed. There may be a variety of reasons for those gaps, but some of them that are noted by our study here may reflect inequities in the distribution of resources across the state. But it's important to note that our study did not include an assessment of provider supply, and that the service area maps that Dr. Pourat displayed earlier do indicate that certain geographic locations offer few or even no CBAS or MSSP providers or programs. Our estimates of those potentially eligible but not using these programs also show that certain population subgroups within particular geographic areas are underserved. And I think this suggests that targeted outreach and strategies to increase access by geography and by prospective participant age, race or ethnicity, and other demographic characteristics are warranted. I'm going to tell myself, next slide, please. There we go. So policy interventions to address the service gaps identified by our assessment include expanding the reach of the MSSP and CBAS programs in California to ensure a more equitable distribution of resources. Available resources could be prioritized for those identified as underserved and having unmet needs for supportive services. Some strategies to increase access to care might include growing the provider network to ensure that CBAS and MSSP programs are available in all of California's geographic regions, improving communication about available programs and services, and easing pathways to program information and enrollment. At present, many people are unaware of the services available or lack knowledge on how to access them. Streamlining eligibility requirements and simplifying application processes can help. I think this project's identification of current and estimated eligible users of MSSP and CBAS, together with the projected number of future potential users statewide, can be used to help plan, promote, and appropriately target these services moving forward. I think at the end of the day, these efforts can help to prevent or delay unwanted, unnecessary, and more costly institutional care. So we're really fortunate that the current policy climate in California is ripe with innovation and a commitment to improving population health for all, but also with welcome and needed attention to the specific health and wellness needs of older adults and adults with disabilities. Some specific initiatives that are designed to support the needs of people who can benefit from programs like CBAS and MSSP include the Aging and Disability Resource Connection, CalAIM, and California's Master Plan for Aging. Programs such as the Aging and Disability Resource Connection, or ADRC, provide a no wrong door approach to developing a more coordinated system that provides consumers with the information and supports they need to access a wide array of LTSS and other needed health and social services in the community. The ADRC is where the rubber meets the road. I think it's a practical intervention to help individuals and families who have LTSS needs sort through what's a very complex quagmire of health and social service systems in our state, to help them understand and access available benefits and supports. CalAIM, which seeks to transform Medi-Cal, in part by bridging traditional medical settings with home and community-based services, is really well aligned with the focus of LTSS care delivery by improving coordination and delivery across a broad range of services that address social determinants, and by taking a more holistic approach to serving the whole person. The principles of CalAIM align well with the person-centered goals of LTSS in programs such as the MSSP and the CBAS programs. And finally, California's Master Plan for Aging really provides the momentum, the long-term investment and commitment to improve access to programs and services that promote health, well-being, and independence among older adults and adults with disabilities. And all of this is done through a lens of health equity, so that those who have been underserved are identified, their needs are addressed to ensure that no one gets left behind. And in conclusion, it's our hope that this needs assessment is a starting point. It can provide a framework for the evaluation of other LTSS programs, both individually and also across programs and systems. The ultimate goal is to ensure that the scope and reach of programs that respond to the chronic care needs of older adults and adults with disabilities is adequate, and that all those who need them and can benefit from these programs have equal access. So I think we'll wrap it up there. We do have time for questions. I'm going to turn it back to our Director of Communications, Tiffany Lopes, to facilitate our discussion. Thanks.
Thank you, Kathryn. And if you wouldn't mind just switching over to the next slide so I can drop in the links to the policy brief and the infographic, which I'll put in the chat right now. And then the next slide for questions. So thank you to both of you for the presentation. We're going to be going through the audience questions now. I encourage you to use the Q&A function in Zoom to ask questions. So let's get started with the first one. Can you let us know which CHIS questions you use to identify the unmet needs? There are some that ask about everyday needs and some that ask about personal care needs.
Actually, the CHIS questions we used identified the type of disabilities. They're American Community Survey questions that identified people with disabilities in personal care, people who had needs for things like bathing, dressing, people who had needs for routine care, things like getting out of the house to shop, doing housework, and then also people who had difficulty with cognitive issues, had difficulties with concentrating, remembering, or making decisions. So the needs in our assessment were not based on that, but people who were identified through the CHIS as likely to be eligible for programs like MSSP and CBAS. Those questions helped us to develop a model to make those estimations.
Thank you. How do you account for non-Medi-Cal eligible populations that might need CBAS and MSSP, assuming agencies providing those services also serve non-Medi-Cal eligible patients / clients? If you don't, how can the Department of Aging know the full picture of need for these services?
That's a great question. We had to make a decision that what we were really going to focus on were individuals that were currently receiving Medi-Cal. It clearly leaves out not only those that might get some services, but those who become eligible and because of their disabilities, etc. So I think that we could not really develop a model that would predict that at this point. So that's the route that we took. The question is it's a good question, of course, because we know that there are, things change, people become eligible, and to the best of our knowledge, well, CBAS, you cannot, well, presumably you can use CBAS with private pay or other forms of payment, but we primarily were focusing on the Medi-Cal enrollees. Kathryn, did you want to add to that?
No, I think that's a good answer. Thanks.
What kind of outreach is done from these programs or from Medi-Cal to let people know that they are eligible?
That's a very programmatic question.
Yes, I'm not sure that actually it is Medi-Cal that informs individuals, at least for CBAS. I think that it's the CBAS Center providers that might do that kind of outreach, and whether it's word of mouth or other forms of outreach to let people know. Programmatically, I'm not sure how Medi-Cal, apart from the website, and there are places you can go to understand the benefits that are provided. I cannot tell you about the direct outreach by the program.
Yeah, I agree with you, Nadereh, about that. I think that the outreach for these types of programs is much more typically coming from the Aging Services Network. I mentioned the Aging and Disability Resource Connection, so that's a prime example of a program that would provide information. All of the area agencies on aging in California, which represent all of the counties, have an information and assistance hotline. And then I think very importantly, that word of mouth, especially for the CBAS programs, which, as I mentioned earlier, often serve very specific ethnic population groups. I think there's a lot of word of mouth that gets circulated about those programs that are within the community and really well designed to serve the local community.
CMS data considered for analysis?
Did we use CMS data?
Yes, or was it considered?
I assume the question is about Medicaid data. No, we did not use Medicaid data. There are, that data frequently has significant lag, and it's more or less equivalent to what information we received from California Department of Healthcare Services. So indeed, I think you could argue that the information that you get directly from Medi-Cal is perhaps even more comprehensive, and it's much more timely source.
Thank you. What is the cost to the state to provide these types of services, and how much would it cost to fill the current gap?
We need our colleagues from the California Department of Aging to answer that question. I don't think either one of us can tell you what the cost is. I think the amount of the payments for CBAS per individual, I think that's publicly available, though I don't have that at the tip of my fingers. I don't know about the MSSP. Kathryn, do you know?
No, I think I'd have to defer to our California Department of Aging and colleagues in Department of Healthcare Services.
If anyone's on from CDA, if they want to drop that in the chat, if they're able to. Has the state budgeted for an increase in MSSP caseworkers to manage an increase in eligible clients? And is there a proposed budget to help assist new clients coming into these two programs?
Again, I think we need to have our colleagues from CDA on the panel with us. Sorry, I'm not aware of what the budget planning is for increasing caseworkers.
Right.
I know there's a cap on the MSSP program. And so that does limit, obviously, how many they can serve.
I think we could say that, clearly the California Department of Aging is thinking about some of these issues that are coming up. And they obviously were interested in understanding what the likely demand for the services are. So I think we encourage you to communicate with them directly, but that the considerations that you're bringing up, I think, are top of mind.
Thank you. Are there enough CBAS programs and MSSP providers in place to handle the number of people that are not currently receiving services but eligible?
We didn't look at the supply other than looking at the maps and having a number of providers. But I think if you look at our estimates of how many are served and how many potentially could be served, it would appear that there would not be enough to address that tenfold demand, potential demand, for example, for the MSSP program.
I mean, thinking about those, the CBAS providers obviously are organizations, and they potentially have ability to expand to some degree. But as I mentioned earlier, the distance to a provider could be an issue. I think that with MSSP, the picture is a little bit different because you're talking about social workers and case managers and individuals that are working, perhaps more individuals, and the reach of these type of providers are different. But what Kathryn said and what we presented earlier tells you that it appears to be more demand that the current supply could address. And that's, I think, something that the CDA is examining.
Could CBAS/ADHCs provide programming for unhoused older adults or persons with disabilities?
It's a really interesting question. I mean, on the face of it, I don't see why they wouldn't be able to. I mean, if assuming that those individuals qualify under the eligibility criteria that's set out, the challenge may be getting the documentation from unhoused individuals, obviously not having an address of record. And the CBAS programs, as I understand, they have transportation services to those who need them to get them back and forth. But for someone who's unhoused, it introduces a different element. But I think it's a really important question and something that needs some thoughts. I'm sure people are thinking about this already and perhaps also doing something about it to ensure that people who are unhoused are getting the kinds of services that we're presenting here today. Yeah. Certainly, there are a lot of additional challenges that are introduced when someone's unhoused and potentially doesn't have documentation and other information that would be required to get them into a program like this.
Yeah. So was the question also including individuals with disabilities?
Yes.
It's somewhat of a different picture. I think as far as I know, obviously you need transportation and has to be capable of dealing with individuals that might be using wheelchairs or assistive devices, which I believe they do. And the facilities also have to be able to accommodate if we are talking about, developmental disabilities or other individuals with other cognitive situations, if it's Alzheimer's or so, then, those considerations are important because not every facility or provider, especially with CBAS, may be equipped to provide the care that's needed. So those considerations are also important.
Thank you. Someone says these are relatively small LTSS programs. How many Medi-Cal beneficiaries are receiving other LTS services, for example, IHSS?
Yeah, IHSS is a much larger program. and serving, last number I recall, at least 500,000, I want to say, Californians are recipients of the in-home supportive services program. It's probably the largest program that falls under the definition of long-term services and supports. And for those who may not be familiar with it, it's consumer-directed program where people who have LTSS needs can hire a caregiver of their choice. It can be a family member, a friend, a neighbor. If they don't have somebody in that category that they wish to hire or can hire, they go through a registry. But it's a big source of support, especially for personal care needs of people with a range of functional disabilities and chronic care needs.
Mm-hmm. There are small programs, but I think we should think about the significance of their value and how they fit the different types of needs. You know, individuals may have IHSS, but they may also utilize CBAS, or they may require additional help from MSSP. I think when you think about preventing institutionalization, some of these additional, not everybody needs the additional services, but they could be quite crucial. So I think their value is really, it's not their size as much as when they are necessary and can prevent institutionalization.
I think that's a really good point. And part of the challenge is because the programs are financed differently, administered differently, is understanding what people are getting across the systems, which is why having a better understanding of how these programs can operate together and having a case manager who can help walk consumers across these different programs is really instrumental in getting people the sufficient care that they need, the adequate amount of care that they need. It becomes a very complex puzzle in a way to put these pieces together, but sometimes even a few hours of support through IHSS in tandem with some care coordination and other types of services is really what's necessary, and helps people stay in their own homes, which is the goal.
Are MSSP services paid by Medi-Cal now to be provided by managed care plans? If so, how do these services vary by plan?
Good question. You know, the vast majority of people, and moving forward, almost everyone's going to be covered by Medi-Cal managed care. That's the direction we're moving in. I know that that's a criteria for the CBAS program, is being part of a managed care program. I'm not sure if it's the same for MSSP, frankly. And I'm not sure what that would look like if health plans could decide which services. Again, the MSSP role is really to coordinate across services. And so it's more, as I understand it, it's more of a coordination rather than providing a specific menu of services. It's identifying the services that people need inside or outside of the managed care plan.
Are your projected populations and needs stratified by income? In other words, do you project these numbers will be eligible for Medi-Cal?
So we identified individuals that were at the income eligibility level. If you recall that slide when we identified the pool of likely eligibles. I think this question is somewhat similar to the other question about people who don't currently have Medi-Cal but are likely to have. So we did not really go beyond the current likely eligible people who fit the criteria, because that would be separate type of analysis and modeling, which certainly can be done to understand how the pool of likely eligibles is going to change with income. But beyond narrowing the pool to those income levels, I don't believe we added more to the analysis to predict.
We have time for a couple more questions. So if you do have questions, please drop them in the Q&A. Is hospice care an aggregate component of the data collected? Can you report on that specific service in the future?
quite sure I understand the question. Is hospice part of these? So could you repeat it?
Yes, is hospice care an aggregate component of the data collected?
We
think
don't we
yeah.
don't have service use specific as
Mm.
part of the models that were developed. So I think the answer to that is no.
And if not, is that something that can be reported in the future?
Should we think
So-
about hospice as a way of, so when you think about these LTSS services, I guess you could think of hospice as a long-term support. It's not really a long-term support. The idea of hospice is, as I understand it, is for individuals that have a poor prognosis, right? So it's really an end of life care. And often it is an overlay on whether an individual is in a nursing home or at home, or perhaps even in the hospital. It's an overlay service. So I don't think we typically think of it as a long-term support to prevent institutionalization.
And then the last question is also more of a question for CDA, but I'll read it. In LA City, people who attend the recreation and parks senior centers don't have easy access to the information that is easily available at the multipurpose centers. Can there be staffing available to this population to get this information? And then someone else also asks, can staff of the City of Los Angeles Department of Recreation and Parks senior centers be trained on this information?
Excellent points. Well, I'm not sure we have an answer to either one.
Yeah, and I think just to clarify, I get confused by this a lot. They're multi-purpose senior centers, and then there's the multi-purpose senior services program. So what we were analyzing and assessing here is the latter, the case management care coordination. The senior centers is a very important community service for local communities where older adults can gather, congregate, have meals, etc. But different than what was included in our analysis for this project.
Thank you, Kathryn. So those are the questions we have today. I just want to thank you all for attending this month's webinar on aging and disability services. A few people asked in the chat. We will be posting the recording of this webinar online with closed captions in the next 2 weeks. You can visit healthpolicy.ucla.edu/seminars. If you'd like a copy of today's presentation or you would like us to send you the link to the YouTube, you can also email us at healthpolicy@ucla.edu. Thank you so much for attending and have a great day.